Hi, I'm Rhonda Orndorff. I'm a Colorado State University Pueblo DNP student. Today I'm going to talk about primary care providers and their ability to affect weight loss among overweight and obese patients. Obesity is a public crisis leading to increased healthcare costs, comorbidities, self-image, and psychosocial issues among patients with obesity. There are many barriers identified both with providers and patients, which make it difficult for the patient to achieve these weight loss goals. I've identified through literature research that counseling, lifestyle modifications, and pharmacological therapy do improve weight loss trends to a varying degree. I utilized search engine SINHAL, EndNote, and PubMed using keywords identified here in this slide. Currently, my PICO question is, in overweight obese patients as defined as a BMI of greater than 25, how does 30-minute primary care provider visits every month for weight loss counseling compared to 15 minutes every 3 months influence weight loss over a 6-month period? To incorporate this into practice, I propose a quality improvement project. This is important to me because we've identified through Centers of Disease Control and Prevention that obesity is a public crisis affecting 93 million adults in the United States, accounting for $147 billion annually in healthcare costs. In Colorado, our rates have doubled in the last 15 years, and in Pueblo, Colorado, our obesity trends are at 30%, which is higher than the Colorado average. For me personally, as a primary care provider as well as a cardiology provider, I have seen the comorbidities of stroke, myocardial infarction, hypertension, hyperlipidemia, diabetes, as well as many others that have the risk factor of obesity. Many of my patients, anecdotally, are obese or overweight with these comorbidities. I find that myself, I try very hard to focus on diet and exercise education during these visits, but it is hard to discuss when you have so many other comorbidities to focus on. There's no consistent process to follow these patients to see if they do have a weight loss trend over a period of time. Currently, these are the stakeholders that I've identified in the middle. I've identified some barriers to the side. For the patient and the provider, some of these barriers overlap. For the patient, some of the barriers that I perceive are the opportunity to discuss weight loss or weight counseling at each visit. This again trends to the provider's ability to discuss all of the comorbidities and complaints at each visit due to time constraints, as well as the complexity of the patient. Back to the patient, lower income level and lower education status trends to higher trends of obesity. This in part is because one, they do not have the money to spend on better quality food, and two, their education is lacking in understanding of what diet and exercise modifications need to be in place for them to lose weight or have a healthy BMI. For the provider, further going into detail as far as the documentation and the number of visits needed, providers have to document so much in regards to each of the conditions to meet billing and coding requirements. To be able to use CPT code for screening for obesity and counseling, there must be a face-to-face visit once a week for the first month, every other week for the months 2 through 6, and at least once a month through months 6 through 12 per CMS guidelines. Now my question is, does this prove to be cost effective for both the patient and for the provider / practice? Community and family barriers that I've identified are the cultural and cultural beliefs. Accessibility, this plays to can the patient get to places where they need to go if they're overweight or obese? Do they need some kind of special assistance to get into these facilities. And there's also the stigma associated with overweight and obesity. For example, do you see morbidly obese patients in the gym, and what would you see other individuals doing when they saw this person? The healthcare system, this trends to increase healthcare costs and other chronic diseases, which again makes it difficult for the healthcare system to combat. So through my literature review, I've identified 4 main studies that I felt were most important to me. Most important was the Whedon et al. Randomized control trial. This one was a 390 participant study of obese patients who had at least 2 components of metabolic syndrome. There were 3 arms of this study. The usual care was a once every 3-month visit in the primary care office. The brief lifestyle counseling group had once a month visits, and the enhanced brief lifestyle counseling group had once a month visits, as well as supplements such as protein shakes or Orlistat, a weight loss medication. So in total, the more weight loss was achieved in the enhanced brief lifestyle counseling group as compared to the usual care, and overall, greater than 10% weight loss was achieved in 6.2% of the usual care and 17.8% in the enhanced brief lifestyle counseling group. Drombowski et al. In 2014 did a meta-analysis of 45 trials involving over 7,000 participants. It showed that diet and exercise did prove to have weight loss. However, it was marginal at 1.56 kilograms. Time frame was unknown due to the amount of trials with varying time frames. The other identifiable fact was Orlistat was used and did prove to be beneficial. However, they did have increased GI effects, which led to decreased compliance. Costanza et al. Did a longitudinal study in 2015 over a course of 10.6 years, assessing BMI and prognosis of diabetes mellitus type 2. A Cox regression survival analysis included cardiovascular factors and other comorbid conditions. Overall, the study showed that higher BMI with diabetes did prove to have higher risk of non-fatal cardiovascular events and hospitalizations, but did not trend to mortality of a more cardiovascular event. Bay, Chapman, and Grandy in 2017. Now, this is a study obviously outside of our time frame for literature research, but I found that it was useful because it identified increased BMI with increased prevalence of hypertension and diabetes. What it did modestly correlate with was dyslipidemia, but to a lesser degree as compared to the hypertension and diabetes group. So I felt that this was a good study, although outside of our literature review guidelines. So evidence-based collection. Within most of the studies that I found, they're all quantitative research design and an experimental design. For me, I plan on doing a survey of charts. One, I would need to survey them for the population that I am wanting to address to formulate a population sample group. From there, I will need to use these charts and survey these charts to evaluate weight over a period of 6 months using BMI and or pounds. There are other factors that can be obtained from this, such as blood pressure measurements, cholesterol levels, and A1C. Tools that will be helpful in analyzing my data would be the chi-square testing as well as a correlation and regression analysis. This is the organizational structure I will be working with. I've identified the main hospital, Parkview Medical Center, as the overlapping entity. From there is my current practice, internal medicine clinic, which has 1 clinical practice manager, 4 providers, 1 lead clinical, and 3 office staff, and 4 medical assistants. I place the specialty groups to the side of the providers because they will have some kind of impact on my study or my project, as they will be seeing these patients as well, because again, a lot of these patients have other comorbidities. The challenges and barriers that I face are: one, institutional review board. I find that I expect to see some delays in the IRB process because, one, I've never done it before, and two, there may be differences in recommendations and requirements amongst the university compared to the hospital. So we'll see. Sample population. I think that I will have to do an extensive review of the charting system to identify the population, and then from there the sample population I will be wanting to work with. So that'll take some time to accomplish. A compliance among participants. I'm a little nervous about the frequency of these visits and the compliance issues amongst these patients. Will these patients have to pay a copay? Are they able to find transportation to the visits? And then also, are they going to want to put in that time and effort? Compliance and intervention set by the provider. Again, going back to the billing and coding, are these providers going to want to continue with having these monthly visits if it doesn't find to be useful for them as far as the billing and coding, and as well as RVU production? Also, it goes to the fact that the time frame, are they going to have the opportunity to go through all of the interventions, and are they going to be the same consistent interventions? Compliance with provider documentation and education. Again, it just goes to, are these providers all going to be documenting the same? Are they all going to be educating the same? And so I find that I will more than likely need to have some sort of toolkit to educate the providers in what needs to be established at each visit. And then this goes to the next thing of inconsistent education among providers. This is overall the evidence table, again, of just the four main components, main studies that I felt were most important. It goes through the research variables, the comparison, the outcomes, and the quality improvement project, as well as the theoretical framework that is being used in each of these studies. So in summary, obesity is a public crisis which will need a multifactorial approach involving all stakeholders. There are barriers to achieving weight loss from a provider standpoint. It is lack of time and documentation to provide that assistance to be beneficial for that patient. Counseling is beneficial to a modest degree for weight loss, but may not be cost effective overall. And so that would then trend to the lack of consistency and follow through with the intervention. Pharmacological therapy is useful, however, it does have its limitations. As noted in previous studies, there's that GI effects, so that again may lead to non-compliance as well. For me, the Wade et al. Study proved to be the most similar to my intended project. It is a randomized controlled trial with regression analysis. I really liked that study and felt that it followed very closely to what my goals for my project are. To reduce variation between the providers, I think the Six Sigma model is an important model to follow to reduce that variation. And then also for my quality improvement project, as we've noted in previous discussions, the Plan, Do, Study, Act strategy is most beneficial for this project. And these are my references. Thank you.